Good evening. Welcome to the international webinar at Believers Church Medical College Hospital. I extend a warm welcome to our faculty, students, delegates from across the nation, international diaspora, and education partners. Today, we have a unique topic, one that is resonating across the globe, one that is changing the game in every industry, one that is subject to great debate, one that tries to enable and even outsmart human intelligence, one that entrepreneurs swear on. The medical field, especially oncology, is no exception. Artificial intelligence has taken the world by storm. And to throw some light into the role of artificial intelligence in oncology, we have the principal investigator and facility head, Microscopy Core, Cancer Science Institute of Singapore, consultant, Department of Hematology Oncology, and assistant professor of general medicine at the prestigious National University of Hospital, Singapore, Dr. Jayasekaran Anand Prasad. A great Cambridge scholar for the PhD in oncology at the University of Cambridge, UK, Dr. Jayasekaran has blazed his trail right from his graduation in the prestigious CMC Vellore. Following a postdoctoral fellowship in Cambridge, as a junior research fellow, he joined the National University Hospital Singapore in 2010 to complete his training in internal medicine and medical oncology. Member of the NUH lymphoma team, Dr. Jayasekaran's clinical interest is in aggressive B-cell neoplasms. His laboratory focuses on understanding how the immune system clears chemotherapy-treated cells, and his clinical research is on combination therapies in lymphoma. He holds multiple internal and nationally funded grants to support his research and is also actively involved in the clinical scientist unit at the National University Hospital. He's also a co-lead for the molecular diagnostics platform in the Singapore Translational Cancer Consortium, STCC. Physician, scientist, thinker, genius, and administrator, we welcome Dr. Jayasekaran Anand Prasad to our international webinar. Sir, it's a great honor and privilege to host you. Over to you, Dr. Jayasekaran.
Thank you, Jacob. That was exceedingly kind. I must say it's a great pleasure to be here, to be able to talk to you all at the BCMCH about a topic that is sort of close to my interest, and also something that many of us have been thinking about in the field. And so maybe without any further ado, I'll jump straight into it. Jacob, are we okay with my slides?
We are not able to see it as of yet.
Just a second. Does it work now?
Not yet.
Oh, this is annoying. Sorry. Every time I do it, it says my screen sharing is paused. Is there some setting that
you need to minimize any, if there are any other windows, minimize it and keep the PowerPoint open, then it works.
Okay, just give me a second.
So if there are any folders that it is opened and kept, I just minimize it down. And now, sorry, you can double click to enter full screen mode. What is that?
I apologize. Something has. Every time I do it, it tells me the same thing again.
It just came. It just came.
Did?
It just came and left. Yeah, we've got it again.
Okay, great. All right. Sorry about that. So let me get started. So you can see my slides now?
Yeah, that's perfect.
Okay. So yeah, once again, thanks to Jacob and the organizers at the BCMCH for having me. So I'll jump straight into it. So this to start off with the topic of artificial intelligence in oncology, we must first have a shared definition of what artificial intelligence is. And there's a lot of confusion in the literature about the differences between AI and machine learning and deep learning. And so I thought I'll start off with a quick intro into that. AI is a very broad and a very old term from the 1960s about just trying to make machines think a little bit more like humans. So it could be any aspect of human-like intelligence. And that can be a very simple definition, or it can be a very complex definition. What mostly we talk about these days is machine learning, which is a subset of AI, where machines are taught to think like humans to some extent. Now, I've illustrated these two examples here. We have if I was to ask somebody what is the difference between a Ferrari and a cat, you would think I'm crazy. You wouldn't be wrong, but there's a reason for this illustration, which is for a machine to understand that difference, you could give it a set of characteristics of these two different things. You could say metal, you could talk about the percentage of rubber in each one, you could talk about the percentage of hair in each one. And like that, you could ultimately teach a machine that something that has more metal and more rubber is more likely to be a car and less likely to be a cat. That is machine learning, where you are teaching the machines how to then identify these things out in their test sets. Deep learning, on the other hand, is just giving machines the opportunity to learn by themselves, where you basically give them thousands and thousands of images of Ferraris and thousands of images of cats, and then you ask the machine to try and figure out by itself what are the differences. And it may pick things that you never thought of. It may talk about the position of those two things that stick out of the car versus two things that stick out of a cat. So this is the fundamental definitions of these three things. And I thought it would be important to start with this because a lot of the talk is built around that. So what I want to do today in the next 45 minutes, and bear with me for 45 minutes, if at any point you feel like doing other things, you're most welcome to do so, is to actually go through the journey of a cancer patient and try and understand where are the opportunities for AI, what has currently been done, and perhaps a little bit of our own work here at NUS in this area. So I understood from Jacob that many of the audience will not be oncologists, so bear with me if this is too simplistic, but what I want to outline here is what typically happens to a patient with cancer. So when we think about it, most patients will go through a variety of things from diagnosis to risk stratification to treatment to clinical trials, and all these things happen typically in the auspices of a cancer center. So what I will try and go through is an example of a case study of a patient with cancer. So let's get introduced to our fake patient, Mr. X. And he's a typical guy in his 50s. And we'll try and go through what could potentially happen to him if he was on the cancer pathway. So a standard question that comes up is about normal people and screening. Should we be screening everybody to identify cancer? Because we know that cancer, when it is diagnosed early, can be treated better. So we also know now that for a test to be a good screening test, the bar is very high. So it's only used in very select scenarios. Breast and colorectal cancer are two of them. We know that it is unhelpful in certain scenarios, for instance, in prostate. And we know that it may be too complicated in some others, like in lung. So this is an area where AI has been thought of as an option. Here's an example recently published of a method to predict lung cancers from low-dose CT scans of the chest. Now, low-dose CT scans have been proven to pick up early lung cancers in smokers, but that needs dedicated radiological services to be able to read these. Right now, there are algorithms that can look at the scans and try and identify suspicious nodules. I'm sure most of you will be familiar with this type of a curve. It's called a ROC curve, where we typically plot sensitivity on one side and 1 minus specificity on the other side. Oh, sorry, there's a bit of sound. Yeah. And so what you see here is essentially that the closer to the corner the curve is, the better the test performs. And what we are looking at here is that the model actually outperforms a typical radiologist reading of some of these CT scans. But CT scans and invasive investigations are ideally not what we want. We all want a simple blood test that will tell us, do we have a cancer growing in us somewhere? And actually, cancers do release a lot of substances that can potentially be picked up in the blood. It's just that they are so wide and complicated that we probably need ways to put these together. And certainly there's a lot of effort in trying to use AI-based tools to compare the blood profiles of circulating DNA, microRNAs, and even certain proteins in the blood of cancer patients. This has not come to fruition yet, but we are eagerly watching this space. So now let's take a scenario where this is not screening, it's actually a patient presenting. So in your general medicine outpatients, you will see typical presentations like this. Somebody coming in with vague symptoms, and he's just been dragged there. He doesn't really want to be in hospital. And most of the time, they're just given non-specific treatment and sent back. And typically, there's a delay in the time to an actual investigation being done and a diagnosis being made. This is true all around the world, not just in India. And we typically see a delay of 3 to 6 months before most cancers are diagnosed. There is a need to pick up earlier tests that can do this. Again, I mentioned circulating tests would be ideal, which are less invasive than the current systems of doing scopies and scans and things like that. So at the skin level, this has been addressed with AI. And this is a paper that came out in Nature a couple of years ago, looking at the classification of skin lesions and trying to see whether this could be done through an AI algorithm as well as an experienced dermatologist. And essentially what you can see is that actually these algorithms do perform as well as most, if not all, dermatologists that it was compared to. And this was good enough to identify the differences between different skin cancers as well. So again, that's an example of something that has been used in diagnosis. It's not in clinical practice yet. But let's take our case example. Again, this is a gentleman with abdominal symptoms. And eventually he agrees to go for a colonoscopy because the symptoms are not going away. And they note a lesion in the rectosigmoid region. Now, we can say that lesions come in many different forms. Some of them are obvious, some of them are less obvious. And we do need tools to improve the ability to biopsy the correct site and even miss early lesions. And this is an area where, again, AI has been implemented. This is a paper on how they could use real-time AI monitoring to try and tell whether a lesion has a high probability of being malignant or not. And you can see here that this is a probability map that is generated. And with that, they're able to pick up even early adenomas as well as other polyps. So moving on in this virtual patient of ours, he essentially then has a biopsy which turns out to be a moderately differentiated adenocarcinoma. In a frank adenocarcinoma, it's very easy to make out. But unfortunately, many cancers actually present as much more subtle lesions. And this is another big area that has opened up. So we talked about the ability to look at scans. We talked about the ability to look at lesions on the skin. Again, these are all image-based algorithms. You can see a common theme that is occurring here. And pathology is another image-based specialty, which is very ripe for artificial intelligence. And for anyone who's interested, this is an excellent review by Costa Berra on this topic, on how AI has been implemented in pathology. I'll take you through a few examples. This was a very famous challenge which was published in JAMA a couple of years ago. It was called the Chameleon 16 challenge, where AI algorithms from different universities in the US were essentially pitted against pathologists to try and see whether they could pick up small lesions of invasive carcinoma or nodal metastasis in samples of patients with breast cancer. And what we see is that many of these algorithms perform very, very well in picking up these small areas of metastatic carcinoma. And these have been now built into almost real-time microscopes. So to try and, as the pathologist is looking at it, they can even generate a false color image of where potentially there may be a tumor sample, within that particular sample. And again, the ROC curves for many of these are extremely high. This has also been extended to what's called weakly supervised deep learning, where it adds to the pathologist's interpretation as opposed to just replaces it completely. So far we've talked a lot about diagnosis mostly, and now I want to shift gears a little bit into cancer treatment and how that might be impacted. So we know that cancer treatment is a very multidisciplinary approach. There are many modalities of treatment. There are many teams that are involved in treatment. And typically we have something called a multidisciplinary team meeting for all cancers. Each tumor type have their own, and then they decide on what to do for a given new patient. Some of these things are curative treatments, some of these are non-curative treatments, but all these require multiple disciplines to be involved. So let's take our virtual patient again. He has been diagnosed with colorectal cancer, and typically this is the point at which he reaches an oncology service. Until this point, it is with other disciplines. And at this point, we do scans to try and stage the disease. And then we have an MDT meeting where we try to come up with a treatment plan. In this case, it was a curative treatment plan. So you do neoadjuvant or pre-surgery chemotherapy plus radiation to shrink the tumor, then look for the response, and then do a resection, and then adjuvant treatment with chemotherapy. And this is pretty standard for colorectal cancer. Now, these decisions, these MDTs, there are companies out there that are trying to see how they can develop AI platforms. So the ones that are the leaders in this field are IBM, and they have a platform called Watson. This is not based on Sherlock Holmes's assistant, or this is really about Thomas Watson, who was the founder of IBM. Watson for oncology is a subset of Watson, which has been, there's been a lot of effort into trying to see how you can put in all the information about a patient, the scans, the histological diagnosis, and try and come up by looking at the literature as to what could be appropriate treatment decisions for this patient. Interestingly, the first big paper on this came from India, from Manipal, Professor Somashankar's group. And over there, they basically looked at concordance with a breast cancer tumor board. And actually, they found a pretty high concordance in the range of 97–95% for stage 2, stage 3. It dropped off a little bit at very early and late stages in terms of treatment, but nonetheless, quite interesting and promising. Since then, there have been some negative sort of studies in the US. The US, I must say, is a complicated system because their treatment algorithms, because of the insurance-based system, they tend to be very wide and varied and complex. The NCCN guidelines are much broader than most other guidelines in, say, for instance, Europe or Singapore or anywhere else. So essentially, when we think about management decisions, what we're really talking about is risk stratification. We want to understand how high is the risk that this person's cancer will come back after surgery, and what do we want to do to try and reduce that risk. Right now, we are defining those risk features based on scans and based on pathological features. But this doesn't actually take into account the biology of the tumor. So now this is an area where, again, AI is beginning to come into place. There's a field called radiomics, and the sort of principle of radiomics is that essentially when we think about the survival of patients, there can be good survival, bad survival, And this somehow is related to the underlying biology, but that should show up in some weird feature in the clinical phenotype that we may not fully understand. Remember, I was telling you about the Ferrari and the cat. There could be features that a machine sees that humans may not actually see. So the idea is, can we just take these bunch of pictures and just say, to give it to an AI algorithm and say, I'm just going to tell you which ones come from patients who do well, which ones come from patients who do badly, and you just go in there and look for things that may be, may be different. And this is a system that is being sort of widely explored right now. Similarly, the same thing can be done with pathology. There are many features of a tumor which can be visualized in pathology just by morphology alone, which sometimes pathologists may look at, sometimes they may not look at, but ultimately, can we correlate that with clinical outcome and just ask an AI algorithm to come up with features that it thinks are important as opposed to what humans think are important? And this is a stunning example of this, which was published 2 years ago. This is in lung cancer, and in lung cancer, what they do, you've seen the ROC curves. Again, it's very good at picking up the lung cancer. That is not a problem. But what's remarkable here is that the AI algorithm is then able to differentiate between an EGFR mutant and an EGFR non-mutant lung cancer. Now, this is something that no human eye can do. This is, purely based on an unbiased way that the machine has been able to go in and look at this. So, and then if we return to our virtual patient, he's been diagnosed, staged, treated, and then they go into the phase of follow-up. And typically at this time, we want to, have ways to monitor these patients. Again, I return to blood is the easiest thing we'd like to monitor. And AI is something that is being explored in this context as well. So far, we've talked really about a curative cancer scenario. A stage 4 cancer is a whole different ballgame. So largely in oncology practice, these are two very, very distinct approaches that we take. So in a stage 4 or a non-curative cancer, there's a different set of algorithms that we have to think about. So let's imagine what happens to our virtual patient if he goes into this pathway. So he's had his surgery, and about 1 year later, he's beginning to feel unwell. There's a bit of abdominal pain. So basically scans are done and it shows extensive liver metastasis. So now at this point, this is when in oncology, we start doing a lot of molecular testing and a lot of molecular analysis to try and guide our treatment algorithms. So typically, for instance, in this patient, this is one of my old patients from a long time ago. He went on to receive 20 cycles of chemotherapy plus a monoclonal antibody to EGFR. But during this time, he was very well. We had, attended many life events and had good treatment response overall. But the purpose here is really to try and prolong life. And sometimes in this time, we even consider periods of surgery to try and remove residual disease, and then go back to different kinds of chemo break, then put on some targeted therapy for a while. So fundamentally, these things have allowed many of these patients to live for many years with cancer. So why am I telling you this? Because clinical decision support in the non-curative setting is a very different thing, because it's not so much about just following an algorithm for like what Watson for Oncology could have done for early stage cancers. Typically in this, there are many things to consider in terms of sequencing of the treatment, about the patient's desires, their finances, their fitness, which one is the local problem, which one is the systemic problem. And if ultimately our aim is to make them live for as long as possible and as comfortably as possible, that requires, unfortunately, a lot more of the soft skills that perhaps a machine or maybe even some of us oncologists do not have. But it really involves trying to dive into treating the patient as opposed to the disease at that point. And that, I think, is something that AI will struggle with, empathy. So which brings me to where we stand in current oncology at this moment, which this is my own definition. I kind of feel it's about 30% art and 70% science, and others may disagree with this. But let's see how AI can help with the science part at least. So in metastatic cancer, a big aspect is about the molecular features of cancer, about how we can dive deep into these molecular features. So I need to take a short sort of discourse into what is the biology of cancer and the molecular biology of cancer. So bear with me for a few minutes. So in order to understand the molecular biology of cancer, we have to understand how they evolve. So cancers are not born in one day. They need to acquire many, many changes before a normal cell can become a cancer cell. Typically, this happens in decades. This, in the early 2000s, a very famous review was written by Hanhan and Weinberg, cited more than any other paper ever, to talk about what are the key features that a cancer cell must acquire for it to be different from a normal cell. And this was a very sort of fundamental sort of frame shift in our thinking about what is the definition of a cancer cell. The problem is that there are many thousand different roads that the cancer can take to achieve these same features. So each of these key features can be achieved by a combination of different mutations, epigenetic changes, about almost infinite different possibilities to reach that same final destination. And then each of these features, a signaling cascade, is a very complex pathway with multiple backup circuits. So when one thing is disrupted, many different things take over. And so there's a lot of redundancy built into the circuit. And to make matters worse, these cancers are continuously evolving because fundamentally they acquired the way to not repair their own genomic DNA well. So they are highly evolvable and highly mutable. And what you're seeing is a Darwinian process at a very high breakneck speed. So these cancers are essentially going down a quick and rapid cycle of acquiring new characteristics as they continue to grow. And what this ends up being is that each cancer is actually multiple cancers. You have many different clones within the same cancer. And finally, a cancer is not a cancer by itself. It actually has its own little village. It has co-opted the microenvironment to look after it. It needs blood vessels, it needs fibroblasts, it needs the stromal architecture, and it changes all these things to allow it to grow. So suddenly we go, well, is this just a completely unsolvable problem? Is this just too chaotic to do anything about? But we are humans and we don't like to give up until we've destroyed either ourselves or everything around us. So we try to attack it with everything we have. And I was a medical student in 2000, a fourth-year medical student when this paper came out. And I remember one of my professors in medicine showing this to me. And I didn't understand its importance at the time, but it was truly groundbreaking because what it showed was that just by looking at gene expression, we could tell within one disease there were actually two different types of diseases. And at that point, this was just a fundamental frame shift in our thinking. But now that has very important therapeutic implications because lung cancer is no longer called lung cancer. It is either EGFR mutant lung cancer or ALK mutant lung cancer or NRAS mutant lung cancer. And each of these have completely different treatment. In fact, in the last 2 years, there have been 7 new drugs approved for lung cancer treatment. So all these various features that I told you about, there are a few key pieces of ammunition that we have against many of them. We may not be able to target all of them, but there are targets to many of them. And these are changing the way that we practice oncology right now. And which brings us to ask, should we be then sequencing everybody who has cancer and then putting it to some sort of an AI database and picking out what we should be giving each person? And there are those who very vehemently argue against this, saying that this has, this approach will never work. This is all, complete hogwash. And perhaps, we should just focus on looking after patients well. And I think the truth lies somewhere in between, because there's been a lot of hype about clinical or about these precision oncology drugs. Sometimes they just work for a few months. Sometimes they work for longer. Sometimes they work only for a very small subset of patients. And so really what we need to do is try and think of those aspects. So ultimately, really what we want to be doing is having these molecular tumor boards where we put in, imaging, we put in pathology, we put in genomes, transcriptomes, everything together into a machine learning algorithm, and we come up with options to tell us how do we manage these cancer patients. Now, at the moment, I have to say we are not there yet, because the data modalities and the quality of the data for this aspect is lacking. And we are basically, in the stage of, you put in garbage, you will get out garbage. So what can we do to try and build on this? And, there are many people who are way smarter than me who are working on this problem. And I'm doing a little bit in our center over here on areas that I'm particularly interested in. And I'll spend a few minutes just touching upon some of those. So to my mind, one of the huge problems in oncology is the cost of drugs. And that is because of the rate of attrition in drug discovery. So essentially for every 10,000 compounds that are active, or rather preclinical hits, only one of them will become an active drug. By 250 hits to one drug, but 10,000 lead compounds. And one of the reasons is that there's this thing called the valley of death, where many drugs enter into clinical testing and show some promise, but then don't work out well and then are abandoned. And ultimately, pharma companies try to recover the costs by putting a lot of price on the one or two drugs that make it. So what we need to do is increase this ability to have anti-cancer activity. And what we need to do that then is to actually understand better ways to identify the patients who get these drugs, apart from understanding biology of cancer. So we talked about, integrating the genome and, integrating mutational information. That I believe is one aspect to it, but one big aspect that we overlook then in molecular profiling is the spatial aspect. Because you can see within the same tumor that there is one area that expresses a lot of a particular gene and one area that completely does not. So there are things that we need to take into account, which we are not taking into account when we just mash everything up and put it into a sequencer. So in my lab, we have been working on building multiplexed imaging methods to try and do pathology and molecular staining, but using molecular markers of cancer importance and putting them all together to get multiple information from one slide, and how we can then see which ones are consistent, which ones are less consistent. And essentially the AI part comes, or rather the machine learning part comes here by trying to identify, the machine can actually pick up regions of tumor versus stroma. We can teach it what is a nucleus, what is a cytoplasm, and then measure the marker of interest within these compartments. And this is a piece of work that we recently submitted on what we think is a marker to identify patients who will not respond to platinum chemotherapy in ovarian cancer. And we believe this is important because, if we can avoid platinum chemotherapy for a group of patients who will not respond, we can try them on something else instead. The second sort of key area that I want to touch upon is this difference between personalized medicine and precision medicine. So what we talked about earlier was really precision medicine. So when we think about our current modes of doing oncology, cardiology, any discipline, really, it is you take patients who have a disease, lung cancer, heart failure, and we put all of them together and we give them one drug versus another drug. And then we ask the question, do they do well, badly? Is there a slight increase in the survival? And based on that, we approve certain drugs. Now, this unfortunately is actually working for a small group of patients. And there are many of them for which it does nothing at all, and a few for which it may even do harm. So the current way that we think about medicine is a one-size-fits-all, we treat the disease primarily approach. Precision medicine tries to improve on it a little bit by saying, well, we'll have some companion diagnostics to group these patients together. EGFR mutant lung cancer versus ALK mutant lung cancer. We'll pick up, subtypes of breast cancer that are ER positive or ER negative. Based on these, can we give all of them a particular subtype specific drug? And by that, enrich the group that will respond. This indeed is a valid and important way of doing this. But even within that group, you will see some variations because there will be compensations, and each patient who is EGFR mutant may actually have many other mutations as well that make them either super sensitive or super resistant to these drugs. So ultimately, really what we want is, treatment that is for me as a person or for one person. And this is what we mean by personalized medicine, where we say we will take that patient's own samples or own phenotype and come up with an individualized treatment plan, pulling in all these prior information to try and tell us what to do for that one particular patient. And this is something that I've been particularly interested in my own clinical research. So what I mean by that is essentially we have set up in refractory lymphoma a particular platform called, it's called QPOP, from my friend Ed who developed this. It's essentially a phenotypic optimization platform where what we try and do is we take the patient's biopsy, we put it in the lab, we dissociate it into a multi-drug well, which has different combinations of drugs at different doses. Hello? Yeah, which has different combinations of drugs at different doses. And then we essentially, the AI part here is really about trying to predict or extrapolate from a few data points as to a what's called a orthogonal array, and we come up with a dose response map that tells us how well two drugs may synergize with each other for a given patient. And with that, within a week, we come up with an answer for a given patient. And I want to take you through a few case examples of a few refractory lymphomas that we have treated like this. This is a patient with a rare T-cell lymphoma. It's called a hepatosplenic gamma delta T-cell lymphoma. And this patient actually received 5 lines of treatment, including some toxic chemotherapy cocktails. And essentially, unfortunately, as is typical for this disease, just went through all of them with virtually no response. And at that point, he was in ICU, he was very sick. And we enrolled him on this study where because he had a lot of peripheral, or a lot of the lymphoma cells in his peripheral blood, so we could collect a lot of it. We then ran it on a QPOP platform, and we essentially looked at many different drug combinations, and we were surprised to find one particular combination being extremely sensitive. This combination had been reported in multiple myeloma and in some refractory lymphomas before, but not for this particular type of lymphoma. So, I mean, this patient was pretty much at death's door, so we offered him the option of off-label treatment with this. And this was his white cell count at the time. It was 282,000 in the peripheral blood. I don't know what the conversion is for you all. I guess that would be 282. Essentially, from there on, he went on to have a complete response. His lymphocyte count came back to normal. His spleen, which was very drastically enlarged, came back to normal size. And we actually published this work earlier this year as the first application of such a platform to achieve a complete remission in a refractory T-cell lymphoma. Unfortunately, the patient relapsed sometime during the COVID period. He was from overseas and he couldn't come back to Singapore, and he passed away later. But we've gone on to try this in a couple of other patients. This is a patient of mine with a refractory diffuse large B-cell lymphoma, which is the most common subtype of lymphoma. Many patients have relapse after R-CHOP therapy with this. And again, we did the same with her. In this case, it was a solid mass that we actually biopsied. We were able to dissociate and do the test on it. And essentially what we saw was a strong synergy between two drugs, palbociclib and everolimus, which are used in breast cancer treatment. Again, we offered her the option of going on this, and this is the actual lesion here. You can see that it completely has disappeared with 5 cycles of treatment. What you see here is actually normal uptake by the kidneys and the bladder and the heart. And we received a bit of press coverage for this because this lady was a local Singaporean resident, and the university was very happy with this. So the national newspaper in Singapore covered me and Ed. Ed's lab developed this particular algorithm, and we developed the way to get the samples out of the lymphoma patients and keep them alive long enough to do this. But importantly, more than this one patient, we've done it now on about 36 patients, and about 5 of them we've identified new combinations that we offered treatment with, and actually all 5 of them had some response, and overall yielding a pretty good area under the curve, which we are now hoping to write up as a publication. So the next phase for us is really about how to set this up and convert this into a clinical trial, because ultimately you need to compare this against standard of care, which is when a patient has relapsed on all standard options. Hopefully within, we hope that later this year we need to raise funds towards setting up such a clinical trial, and that's something that is ongoing in our center. And this would be one of the first AI-driven trials in lymphoma. So in the last few slides, I want to sort of conclude over here to say that in oncology, what is my view for the future? I think it is promising. I think we should use AI. I am not one of those who believe that we should walk away from the technology. I think we should use it to define and improve molecular genetics, imaging, radiology, and try and account for some of the heterogeneity in cancer. But there's still a human touch that is important. We need oncologists to define patients. We need to work with patients, and we need to work with machines. And I think it would be foolish not to do either. And ultimately, we would want to treat together. And when we think about artificial intelligence, the way I look at it is, it's basically one person cannot know everything. So really, artificial intelligence is combining the intelligence of many human beings together, and that sum has to be greater than the parts. But important, critical is that we have to be responsible about it. How do we choose the right problems? How do we do it in an ethical way? How do we make sure that this is brought to market in a way that is accessible to people? Places where there are no oncologists should get access to this cheap. There should be ways in which this should be rolled out. And so with that, I'll stop and thank my team and the lymphoma group that I work with. This is our hospital at NUH. And I'll leave you with some snapshots from Singapore. If you ever have a chance to visit, please drop me an email and say hello. Or if you want to watch me fight with the Indian authorities on Twitter about clinical trial design, you're most welcome to follow me over there. So with that, I'll stop, and I'll be glad to take some questions.
Thank you, sir, Dr. Anand, for that wonderful presentation. We really knew very little about AI. We did think that we knew quite some before this, but then you really threw a lot of light through the avenues in oncology for AI. And especially, we were really fascinated with your QPOP system that you have developed, and it's such a it's a great system that you've developed, and I think it's really going to break ground. So all the best for that. And the way you described how cancer has its own little village was fascinating, and throwing that needed light into precision medicine versus personalized versus one size fits all type of therapeutics really was fascinating, to say the least. So thank you so much. And we've got...
My pleasure. Let me see if there are there any questions on the chat or anything like that? No.
Yeah, we did get a few
Everybody's gone to
questions.
sleep. Oh, it's dinner time.
No. We did get a few questions.
Yeah.
We did get a few questions through our WhatsApp. So
Yeah.
one is, one question from our student is,
Yeah.
Can we have some means through AI to reduce the value of death impact?
Value of death. Yeah, that's a great question. Send me an email. Come and work with us. The value of death, in some ways, AI can be applied to any problem for which you have data. The data that we have is all these trials that have failed. We have to go back to them and understand why they have failed. Put in a lot of input into, try and collect all of them together. Put all of them as cats. Put all the trials that have succeeded as Ferraris, and then you try and see what is the difference between them. Now, this unfortunately requires some political will, because different pharma companies run different trials, and their ability to release all this data is a very closely guarded secret. So there's only so much that is in the public domain, and certain aspects are not. Some of the pre-treatment criteria, some of the number of patients screened, some of their molecular information. If only we had access to all this and it was an open system. But there is some of it out there, and I think there are people who are working in this area. But that's a great question, and certainly things that I do think that India is a great place to do some of this, because you have so many people who are clever and scientifically oriented, and who will be able to tap into these public resources and use them.
Thank you, Dr. Anand. I think we can expect that in future. And about the ethics part of it, there has been a lot of hue and cry over the ethics part of artificial intelligence, and especially when it comes to oncology.
Yeah.
How do we handle it? How do we get our patients to accept a diagnosis through AI? That you said that artificial intelligence is more of a combined human intelligence was quite reassuring. But then how do we get it across to the masses? Because that is where we are ultimately heading, right?
Yeah, I mean, I think it's just like anything else. It is not to replace humans. I believe it is to augment the work of a doctor. And really, it is about saying, with it, can you do better than you used to do? It's like an endoscope. Before you had an endoscope, you could only do certain things. Now you have an endoscope, you can do more things. So AI is really just another tool, and it has to be used in the right way. And like any other tool or any other drug, you have to compare it against the standard of care and show that by using it, you are doing better than you used to do. And that's the ethics of it. And until then, we should not encourage people to be randomly doing all this, which is why, even in our center, when we say, our QPOP platform or whatever, it has to be done under the auspices of a clinical research study where the patient understands what they're going through. You've explained everything to them. They understand that there are no other options, and then they choose this. And then, then it becomes ethical. If you just did that for every patient to walk through the door and you charge them for it, that would be unethical, right? So I think that's where the line is drawn.
Thank you so much, Dr. Anand. I can see senior nephrologist and director and CEO of Jayasekaran Multi-Speciality Hospital, Dr. Devaprasad Jayasekaran, listening to us. I think we should hear from him too.
No.
Sir, if you can come in.
That's why it was nice listening to Anand. Anyway, there are some of these things are really useful to a practicing clinician, because at the end of the day, when you are dealing with a malignancy which doesn't behave the way you want it to behave, you really are stuck right now. And as usual, when I ask Anand about what exactly this is all about, this is a tumor culture and sensitivity, what you do all the day for the urinary infection. Like that, you try to find out a specific drug for a specific malignancy is good. And second area which I found very fascinating was the screening of a slide. However good a pathologist, you keep looking at all the cells there, there is a chance that you may miss out cells and you may miss out some abnormalities. Whereas if you train a machine to look at the same cell, same slide, it may end up doing a better job and give you a better result. But at the end of the day, I think it's the touch which matters to a patient. If we do not touch a patient and then work across a wall and give only the details, whatever said and done, there is some part of the human body which you haven't studied or you don't understand at all. That feeling of well-being will never be there, I think. Correct me if I am wrong, but
my
my
father,
friend Dr. Abraham Fencherian and Sarah Kosha are there.
my father and teacher, ladies and gentlemen. Yeah, I think it's important to be grounded in reality, and this is the reality, right? So the patients need our touch, and that's the empathy part that's so important. Everything else is just a tool.
Wonderful to hear from 2 generations of amazing doctors.
And I think, Jacob, you must invite Dr. Abraham Fencherian and Sarah from USA, very senior pulmonologists, critical care medicine, and the pediatricians there.
Welcome, sir. Welcome, ma'am. We would love to hear from you too.
Oh, Elshbo. You're muted.
Unmute your mic, Dr. Abraham.
Hey, thanks so much for sharing the invitation. And Anand, you should be really happy that your dad shared it. And we'd love to hear you speak and read some of the stuff that you've written. I'm sorry we were in another meeting, so we missed part of it, but I'm sure everything went very well. And
thank you so much for taking the time to attend.
Oh.
This must be very early for you.
No, not at all.
Thank you so much, Dr. Abraham Cherian. Good to listen to you. Any of our other delegates, seniors, would you like to ask some questions?
The artificial intelligence in my building has stopped working because the air conditioner has gone off. I need to go find it.
All right. So, yeah, I think that was a wonderful session. And thank you so much, Dr. Anand, Dev Prasad Jayasekaran. You've really taken your time off. I know every second is precious for you. And we managed to rope you in, and that's a blessing for us.
No,
Thank you so much.
I'm always happy to chat to students, and that student who asks those interesting questions, do ask them to email me.
I will do that. I will do that. They would be more than happy to talk to you.
Or find me on Twitter. Those are my 2 favorite platforms. Email or Twitter. Okay.
Definitely. And special thanks to all senior physicians and surgeons and others who have logged in. Thank you, dear students and faculty online and other delegates from India and abroad. It's been a wonderful session from Dr. Anand. And until we meet you with another wonderful webinar on the 5th, that is Dr. Shabana will be speaking to us from Michigan, USA. Until then, let me say goodbye. Thank you.